Good afternoon, and thank you for joining today's virtual roundtable discussion on remote monitoring services. Our presenters will provide a brief presentation and will take questions from participants. Please use the Q&A feature to submit questions throughout the presentation. If we are unable to get to your question, please submit it to coding@aasm.org for follow-up. And now our presenters.
Hi, thanks for everyone showing up to this webinar on remote monitoring services. I know there's a lot of interest from members. So our goal today is to go over the current code set and then also review a couple cases in terms of how these codes may be used. I'll start things off. My name's Charles Bay. You call me Chuck. I'm a sleep neurologist currently working at the University of Pennsylvania. From the AASM standpoint, I'm the current chair of the Coding and Compliance Committee. I also serve as the RUC advisor for the AASM. At the University of Pennsylvania, I also serve as the one of the associate CMIOs for Connected Health Strategy at Penn Medicine, dealing with things involved with telehealth and digital health services. So let's start with the first slide. So as you know, this RPM involves the collection and analysis of patient physiologic data. We'll also touch on RTM. Now, this data is used to develop and manage a treatment plan related to chronic and/or acute health illness or conditions. The graphic on the right there is just to highlight the fact that the Coding and Compliance Committee has worked on an implementation guide that was published in February that you can find on the website. If you're a member, you can download it. It's a living document. And so it is going to be updated as new developments come up, and also in response to questions and concerns raised by members. So if you haven't looked at it already, please go to the AASM website and download it and take a look. So just a little history about this code set. So in the 2021 final rule, CMS determined that practitioners would be able to provide RPM services to remotely collect and analyze physiologic data from patients with acute conditions, in addition to patients with chronic conditions. Before, it would only be for chronic conditions. So the addition of the acute condition management was included. One of the key things for both RPM and RTM is that this should only be done in patients who you've seen before, so for established patients. And RPM services can overlap with chronic or transitional care management services, and the codes can simultaneously be used within a calendar month. However, remember that time spent doing the RPM has to be separate from any time that you spend on care management for the patient, so independent from any visits that occur with the patient. The next slide. So here's some kind of general guidelines or criteria for RPM codes. So there needs to be at least 16 days a month in which data is collected, and an FDA-approved device needs to automatically digitally upload patient physiologic data, and it's not something that can be recorded by the patient and reported by the patient. And this is the really important thing to note, is that the device has to meet the FDA definition of what a medical device is in terms of the Federal Food, Drug, and Cosmetic Act. However, it doesn't have to be FDA cleared or registered. You can't use RPM codes if a more other specific code exists for what you're billing for. And then also remember the time frame in that it can be used once every 30 days, except for 99453. A practice expense code, which is used once per episode of care. The next slide. Now, this is a lot of codes, so we'll spend a couple of minutes on this. Most of you are probably familiar with this code set, but it always is worth going over, what each code represents. And so the first one is the initial RPM code that was published and able to be used by everyone before 2021. However, as you can see, I think because of the requirements for using this code, it wasn't really used that much. It does involve the collection and interpretation of physiologic data, again, digitally stored and transmitted by the patient and or the caregiver to the physician or other QHP. And the key here was that you needed to have a minimum of 30 minutes of time every 30 days. So I think many providers did not use this only because of the fact that for the work they were doing, it was oftentimes hard to get to the 30-minute mark to then be able to bill for this code. However, since 2021, the RPM code set has been available. And there's two sets of codes. There's the practice expense codes, and then there's the physician or the provider work codes. So 99453 and 454 are practice expense codes, as you can see there, and related to the device deployment and also the actual collection of the data that you're going to use for managing a chronic condition. And then the next two are more specific for blood pressure monitoring, because a classic use case for RPM has been blood pressure monitoring and then also continuous glucose monitoring. But there's two specific codes, the 99473 and the 99474 codes, which pertain to blood pressure monitoring. Next slide. So the ones we're interested in would be these two codes for treatment management services. So the 99457 and the 99458. I think most of the time, individuals or providers will bill for the 457 code, because as you can see there, it's because of the fact that as long as there's 20 minutes worth of work done by the provider based on automatically collected physiologic data, then this can be billed. And then the 458 code is just that if you spend more than 20 minutes on top of the initial 20 in that 30-day period. And so I think for our purposes, I think people are thinking about this in terms of CPAP management. Probably the 457 would be more than enough. Next slide. So this is now very of interest to many individuals, because in the final rule for 2024, this code set was finally published. So where CMS allows the use of a medical device, again defined by the FDA, to monitor the health of a patient or response to treatment using non-physiologic data. Now, what does that mean? And so they highlight four kind of clinical uses for RTM codes. So things that you would use to monitor the musculoskeletal system, respiratory system, medication adherence, and therapy response. So in terms of the types of data that can be used for RTM monitoring includes objective, either device-generated integrated data or self-reported patient data. And again, different than RPM, this is data that can be sent from the patient to the provider. And it's important to know that the data is reflective of how the patient's doing. So therapeutic responses that can provide a functionally integrated depiction of the patient's health status. Next slide. Now, again, this is just the quick overview of the current codes available for remote therapeutic monitoring. Similar to the RPM, you have practice expense codes highlighted there, and then also the codes that are used for actually the work of kind of doing the treatment monitoring and management based on the data sent in from the patient. And you'll have access to these slides, so I'm not going to bore you by reading these slides. Next slide. So I just want to highlight the difference between RPM and RTM, because I know I've gotten a lot of questions about, what is the difference? What's the best code set to use? So I think this is just a high-level comparison of RPM versus RTM. So I think the key difference is on the top line there, is that RPM codes involve physiologic data that is collected by a device. So it's nothing, even if a patient were to monitor, say, their blood pressure, they can't send it in. The blood pressure cuff or the device has to be able to send it automatically back to the provider or the practice. Versus RTM, this is anything that's data that's non-physiologic, and this could also include self-reported patient data in terms of symptom management, side effects, things of that nature. It's like, how are they doing since starting a treatment? It may or may not involve questionnaires. And so I think the next slide is important as well. Just to be safe, just know that it's probably best to build these codes in the context of an existing established patient. The interesting thing is that for RTM codes, if you read the analysis on how to use these codes, the CMS, I think the spirit of the RTM codes is that these are expected to be done after interacting with the patient with a treatment plan, but in their final rule, they didn't explicitly say that it's for an established patient, just like they did for RPM codes. But it's expected that they're going to probably revise that just to be very clear. And then it's important to know that for both RPM and RTM codes, that only one practitioner can bill for these services in a 30-day period. And an interesting note is that other next bullet is that RPM and RTM codes cannot be billed by the same practitioner in the same month to prevent time being counted twice. And in terms of the 16-day collection requirement, I think this probably is obvious if you take a good look at the codes and the definitions. The practice expense codes are the ones that require the 16-day data collection, but the codes that are used for the therapeutic management and analysis of the data don't require a 16-day data collection. And let's see. Okay, next slide. And so this is just kind of a general summary of what to think about when you're going to consider using either RPM or RTM codes in your practice. So sleep physician centers often assess CPAP efficacy for patients with sleep apnea and compliance through remote physiologic monitoring and PAP devices. So 99091 and 99457 are two physiologic monitoring codes that will allow you to capture that work that you do on a daily basis when you are reviewing this PAP compliance data so that you can help patients become compliant and, for that matter, stay compliant in between clinic visits. That's just the next table just shows the codes that will most likely be used by a sleep provider. An important thing not to forget about or ignore is that it is important to get patient consent. Even though it may not be clear in terms of possibly RTM codes, I think, just to be safe, there's no harm in getting consent, because the worst thing that could happen is that even though it may not be explicitly, stated or clear in your reading of the documentation from CMS, just if you get consent, then there's no way that anything can be really brought against you for doing anything without the patient's knowledge. And again, just best practice would be to do this only for established patients. It's important to know that even though there may be a team of providers collecting the data, the RPM, RTM codes really should be billed by one provider. And sleep practices really should understand and assess any potential liability and risk before you go ahead and implement and provide RPM or RTM services. Things in terms of licensing, consent requirements, as we touched on, HIPAA compliance in terms of the data transmission and also collection and storage, any medical liability issues. And also, too, in terms of reimbursement, it really varies. And so, CMS has some recommended values for how much reimbursement can be collected from this code set. But also, too, really important before you embark on using these codes, check with your local payers. And because each payer has a different policy and even maybe a different reimbursement rate for these codes. So it's really better to get all the information possible before setting up this a program to use these codes. And then also too, balance the cost of remote patient monitoring platforms that exist that may help you bill for these codes with the potential benefits of remote monitoring services for sleep patients. The last thing I'll mention is that on November 22nd of 2023, right before Thanksgiving, the OIG issued a fraud alert warning for RPM codes. Apparently, there had been some reports of unscrupulous groups that were billing for RPM services without doing it the right way, meaning that patients would be contacted and kind of like cold called, and then they weren't even sent a device. But then if the device was sent, oftentimes it was an FDA approved device as a medical device. So make sure that is the case. The other thing that was highlighted in this fraud alert from the OIG was that there needs to be documentation that this RPM or RTM is medically necessary. Because they realize that this is important. They want to make sure it's done the right way. But I think it was just kind of a warning that there are eyes on this code set now in terms of how it's being used. So it's kind of like user beware. So it's not to discourage the use of these codes, but just make sure that you get the consent, medically necessary. The device is cleared as a medical device from FDA standards. And so that's all I have to say for this. I think we're going to move now to a couple case examples.
Thanks, Chuck. By ways of introduction, I'm Gabriella DeBruin. I'm a sleep medicine neurologist at Washington University in St. Louis, where I also serve as the executive vice chair for the Department of Neurology. At the AASM, I'm the vice chair at the Coding and Compliance Subcommittee. So I have a couple of cases of examples of how these codes may be translated into a sleep medicine practice. For this first one, let's say you have a 54-year-old woman in your practice. She has hypertension, coronary artery disease, and obesity, and she's coming in for a new patient visit with snoring, witnessed apneas, and daytime sleepiness. You suspect sleep apnea, you order a home sleep apnea test. The test comes back with severe sleep apnea, 37 events per hour, desaturating to 75%. And you see the patient in follow-up, discuss treatment options for the sleep apnea, and together you elect to start auto PAP 4 to 20 centimeters of water. The patient is on board with starting PAP, but a little worried that they might have a hard time adjusting to the treatment. You also want to ensure that the settings are going to be effective and that they're going to be compliant because of the severity of the disease and their sleepiness and all the symptoms they're experiencing. So during that visit, you discuss with them the option of remote physiologic monitoring service. You tell them you can monitor the data that's automatically uploaded from their device, but that this is a service that's billable to insurance, and so there could be co-payments or deductibles as applicable to their plan. The patient is on board, consents to the treatment. You document on the chart that you've obtained consent. Over the next 30 days, you review the patient's download weekly. There's no requirement that this be weekly. Maybe you do it twice a month, maybe you do it once, but you document the time you spent. And then you contact the patient, and based on the symptoms and on the data download that you've seen, you choose to prolong the ramp setting on the device. You also decide to increase the starting pressure on the device from 4 to 8 centimeters. With each episode of contacting the patient, you document the time spent. You don't document a range, you document the exact time. You add up that time for the 30-day period, and you find that you've spent 34 minutes working with this patient over that 30-day window. This is a situation where you could bill Remote Physiologic Monitoring Service 99091, given that you spent more than 30 minutes reviewing the patient's data and adjusting the treatment plan. Next slide, please. Busy slide, apologies, but this is a slightly different case. So 63-year-old woman that you're seeing for obstructive sleep apnea, I've been following them for 8 years. They were doing really well on AutoPAP 14 to 20, but recently lost 85 pounds and have developed pressure intolerance, mask leak, and an elevated machine-recorded AHI. During the visit with them, you make some adjustments. You lower the device pressure slightly. You order a smaller mask cushion. But you want to monitor the response to these changes and determine whether additional adjustments are needed in the coming weeks. So you again discuss with this patient now the availability of remote physiologic monitoring service. You tell them that you have a nurse on your team that can review her data under your supervision, look at it over the next 30 days, and provide them with feedback under your guidance. You explain that this is a service that will be billed to insurance and there could be copays and deductibles, and the patient is on board and consents to this, and you document that in the chart. Over the next 30 days, the RN reviews the patient data at regular intervals. Maybe they find that the AHI improved with the changes you made, but the leak still is high. They call the patient. The patient said, yeah, I'm a little bit better, but I really am struggling with the full face mask, even though the cushion is smaller. Maybe I want something different. They discuss different options. They choose to go with a nasal pillows interface, which you place an order for. They then continue to look at the data over subsequent days and find that the leak is much improved. The AHI is reduced even further with the new mask. Nurse contacts the patient again, has an interactive discussion with them over the phone. Patient says they're feeling so much better. The RN documents the entire time they spent over that 30-day period, and it adds up to 40 minutes. In this situation, you can bill remote physiologic monitoring initial 20 minutes, which is 99457. And because you have an additional 20 minutes, you can then bill 99458 on top of that. think those are the two cases I had. Great.
Okay. Hello, my name is Tracy Bungie. I'm the Coding and Reimbursement Project Manager with the AASM, and I am here to discuss some helpful tips, documentation, coding, and billing. Sleep physicians and centers often assess PAP efficacy and compliance through remote physiological monitoring and PAP devices. So CPT 99091 or 99457 are two physiologic monitoring codes that may capture the work that sleep physicians provide in reviewing this data and assisting a patient in management in between their visits. Providers should report CPT 98978 for monitoring cognitive behavioral therapy with the appropriate documentation. Patient consent should always be obtained and documented in the patient's medical record before providing either RPM or RTM services to sleep medicine patients. Sleep providers should document the time spent assessing, reviewing, and/or interpreting the data in the medical record. And sleep providers should document the time spent communicating with either the patient or a family caregiver, if applicable, along with the details of the conversation in the medical record. Sleep practices should make use of the digital tools to allow providers to provide ongoing guidance and assessments for patients outside of the in-office visit, including the collection and use of patient-generated health data. And in conclusion, remote CPT coding guidelines may differ from public payer payment eligibility and coverage policy guidelines. The ASM would recommend that the providers contact each payer to verify the requirements, as they may vary from payer to payer. And that is all that I have. Thank you. Oh, and if you have any questions that you didn't send in the chat, you may send them to our coding mailbox at coding@aasm.org. Thank you.
Great. As a reminder, please submit any questions you have using the Q&A feature, and we'll review those right now. The first question we have, if we are manually pulling the compliance data from Care Orchestrator or AirView for PAP usage, this cannot be billed because the data is not automatically downloaded?
I can take that. So my understanding of the code, and Chuck, please weigh in, is that it's required that the device automatically record patient data and automatically register that data. So in this situation, the patient is using a PAP machine and they're not each day inputting their use or inputting their symptoms, but rather the machine is recording that data automatically and automatically uploading it or pulling it into AirView or Care Orchestrator, and you go in to see that data that's automatically there. So in that situation, it would be fine to use a remote physiologic monitoring code because the data is being automatically recorded, as opposed to a situation where maybe you have a different device where the patient will then go in and put data at set intervals, but they're the ones that then go in to type that data in. In that situation, you'd not be able to use it.
And right, just to kind of piggyback off of what Gabby mentioned, I think it's also important to note that what you're not able to bill for would be the practice expense codes, since that's the difference between, say, if you're using a blood pressure cuff to monitor blood pressure for a patient, your practice is purchasing these cuffs and then sending it to the patient, which is then collecting the blood pressure readings, sending it back to the practice. And so with CPAP, it's different, because I mean, if you were to bill for the practice expense codes, not the 457 or 458 codes, essentially it might be seen as double dipping, because currently the DMEs are the ones that are kind of supplying the device. And so unless you're doing it if you're supplying your own DME, then I guess that might be possible, but still be careful. Because technically, as Gabby said, that's a different setup in terms of the data collection and how it's being transmitted to a cloud, basically.
Thank you. Second question, would you address how 99457 and 99458 can be used in a hospital-based clinic? Can the MD bill if staff are under the hospital?
I can take a stab at that. I think that the key thing here is if there is a staff that's providing the service and is billing incident to a physician, the important thing is to bill incident to. Both parties need to be employed by the same entity. So for example, if you're in a setting where maybe you're employed by a university, let's say, and there's a hospital-based clinic where the staff is employed by the hospital, because you're employed by two different entities, that staff cannot provide that service and bill incident to you.
Thank you. If the patient is being monitored by electrophysiology in a separate department of the hospital for their ICD data, does that mean we are not allowed to bill RPM for CPAP if it's also in the same 30 days?
I would say so, right, Chuck? I think you can only bill these codes once. Medicare will only take one instance of these codes per 30-day period. So if a patient has multiple conditions, still only one provider will be able to bill an RPM code during that 30-day window.
Right, as long as, I guess, let's see, where's that question again? Here we go, answered. As long as a different provider is taking care of the patient and you're the one attesting that you're providing RPM services, then in that case, that's the instance where, you can't do both, I think, because I take, based on a question, this is someone who's hospitalized again. Because remember, in the outpatient setting, this is in between episodes or visits. And so that's why it's not, you can't really bill for RPM in a visit. It's all activity in between visits that you're trying to get credit for, all the work that's being done. And so I think we're going to have to do a little bit more investigation and certainly maybe post something on the website just to be clear about RPM in the inpatient setting, because I'm most familiar with it in the outpatient setting.
Can these codes be used during an office visit?
So kind of like continuing what I just mentioned there is that no, because this is for any work that's done outside of a visit. So currently, any work that you do on the same calendar day that the visit is scheduled, you can get credit for that if you want to do time-based billing. So then once the 24 hours passes on that, or actually the calendar day passes, then you can, any work that you do for the patient in relation to physiologic data, you can use the RPM code set.
For CBTI, you said to use 98978 for RPM. This seems to be for the cost of supplies to complete RPM only. What codes should be used for the time spent reviewing the data?
I may have misspoken. I don't think I mentioned that code because if you're using these codes for your work based on, for RTM, I guess, the therapeutic monitoring codes, that would probably be applicable for the CBT, is that it would be I forget exactly which codes there, but let's see. I'm going to pull it up. It would be the 899.
It is what the question was on. I think I mentioned it. I apologize. That it is 98978 for monitoring cognitive behavioral therapy with the appropriate documentation.
Okay. Got it.
Can any non-physician bill 99457 or 58, such as a medical assistant?
Well, it has to be a qualified healthcare provider. So, someone who is licensed to, based on this, I think, scope of practice. And so should be able to, but again, it can't be a team of people doing the work. It has to be one individual doing the work to then get the credit for the RPM code.
Yeah, it's defined as clinical staff that can bill incident to the physician. So definitely nurses. I suppose a medical assistant would count, right, Tracy? If they can bill incident to that physician.
Dan, I'm not sure. I would like to do a little more research. If you could send that one, whoever had that question. I don't, off the top of my head, I don't think that a QHP would include MAs, but let me do, just to make sure that we get an accurate answer. I could do some research on that.
Can these codes be used for Inspire usage review?
I suppose if there's 20 minutes worth of work in between outpatient visits, yes. But no, actually, this is a good one also to send to the email, and we'll take a deeper dive into this. But if you apply the regulations of, the definitions for RPM billing, that should work.
Yeah, I agree. It's physiologic data. It's being automatically captured by the device. It's an established patient. You're monitoring it between visits. If you document the time, I think we can do a little more digging, but I would agree with that. It seems to check all the boxes.
Oh, and there's one other thing that I forgot to kind of highlight also as a requirement, that in addition to the 20 minutes worth of work, there has to be at least one interactive communication with the patient. So it's not just the fact that a person is looking at the data and then not communicating with the patient. So that has to be done and documented as part of that, 20 minutes of work in that 30-day period.
I think you just answered the next question, but I'll read it. For RTM monitoring, could sleep diaries be utilized if reviewed between visits and sent to us from patients?
Sure, as long as you interact with the patient.
What codes can be used for reviewing pulse oximetry data with PAP usage?
So I think in the context of these codes, that there's a number of things. So you could use a code for device setup. You could use 99454 for monitoring the pulse oximetry data if you're collecting it 16 or more days over a 30-day calendar period. And then since it is a physiologic parameter, if it's a medically approved device, you should be able to use 99091 if you're reviewing that data and you documenting your time and you have an interaction with a patient to make adjustments to the treatment plan based on that data. You can only bill the practice expenses 99453 and 454 if you're the one that's supplying the oximeter, of course.
The next question is for Dr. DeBruin with regard to case 2. First 20 bill for 20 minutes is labeled as initial. Initial does not mean that it's at initiation of therapy.
No, initial means the first 20 minutes you spent in that 30 days. So you only get to bill 99457 once in the 30 days for the first 20 minutes. And then the clock restarts. And if you hit an additional 20 minutes, that's when you then bill 99458. So maybe you could say first 20 minutes and then subsequent 20 minutes.
Thank you.
And I think that's an important detail, is that for any additional work, if it's 15 minutes above that initial 20, you can't build the 99458 code.
If the practice purchases the PAP unit and dispenses to the patient, are we able to bill for RPM code 99454?
Yeah, I think if you have the device and you are setting the patient up with a device and you're providing education on how to use the device, then 453 and 454 would apply. Having said that, those codes should only be used if there's not a more specific code available for that. I don't set patients up with PAP in my practice, so I don't know if there's a more specific code for CPAP setup. But in the absence of that, if you're providing the patient with a device and providing them education and capturing the usage, then you would own that piece of the code because it's your device. As long as it's not done on the same day as an E&M service. Chuck?
But however, I wonder about that just because if you're buying the device and providing it, are you still billing insurance, to get the cost of the device back? And so I think it gets still back to the issue of the unique situation of CPAP in terms of the data that's being collected is being transmitted to a cloud-based database, either ResMed, Philips, or I think 3B. And so I know there's a lot of thinking being done about when can, as a sleep provider, when can you build the practice expense codes? Honestly, I think it is difficult to do that. The nice thing is that you don't have to build those to build the therapeutic monitoring codes, the 457 and 458. So I think if you focus on that, there isn't even a data collection requirement, the 16 days. So again, I think that's something that our group is going to talk about more, just to be clear on what the regulations will allow. Because I think it's clearer in terms of blood pressure monitoring and glucose monitoring, because truly those practices are providing patients with the device that they're purchasing, and they're only getting reimbursed for the data collection and the work being done based on the data that's being collected.
If we talk to a patient for 35 minutes, are we able to bill both 99457 and 99458, or does the 99458 have to be a total of 20 minutes?
I think Chuck mentioned that it has to be a total of 20 minutes. It can't be a fraction.
Right. So if it's 39 minutes, no, you can only do the 457. But if you go 40 minutes, yes. 40 minutes and 1 second.
Is it double dipping if the practice has to pay extra for connecting the CPAP to cell service under ResMed or for the Monitor type program?
I'm not sure about the double dipping part, but the person asked the question asked about Monitor, and there's other similar, I think, providers in this space. So that is talking about a software as a medical device. So I know that platform and others are approved for that purpose, for collecting the data and then providing it back to the practice. And so I think that's where it's cleaner in terms of, if you're using one of those SAMD approved devices, then you could bill for the practice expense and then for the therapeutic monitoring codes.
Are there types of visits that RPM or RTM should not be used for? For example, it would be very useful for annual PAP check or compliance visits between 31 to 90 days.
So
I'm gonna
these
jump in on the-
codes. Oh, go ahead.
ahead.
No.
So, okay, a lot of physicians will use 94660 for the initial CPAP initiation and management. What are your thoughts, Dr. DeBruin?
I guess I was, in terms of, are there specific types of visits that they can, I think one of the things that Chuck mentioned is these codes are meant to be used between visits. So are there specific time windows that they're particularly helpful? I think it depends on what you think your patient needs. Is this those first 30 days after you set them up and you really want to make sure that they're doing well? Is it really at the tail end of that 90-day period to make sure that they're hitting the compliance? But this is billed not on the same day as your office visit and cannot be added on to an office visit code. So it's worked on in between in a 30-day window.
And I thought about this kind of, when's the best way to use, say, RPM codes? Because I think the spirit of the, code set is not to do indefinite monitoring, and so you're billing the patient forever, every 30 days. I know some might like that to be the case, but I think it makes sense to do it maybe for the first 90 days after someone gets a new CPAP machine until they're compliant. So if it takes them 3 months to get compliant, then I think that makes sense because you're managing the patient in between visits based on physiologic data. And if a patient happens to become compliant in the first month, then you're only maybe not even doing any work. So then technically you may not even be able to bill the 457 code. Now, I think the way this question is asking it, I think this is going to be helpful for spot checking patients, meaning that if someone calls with some issue that say they can't use it anymore for some reason, nasal congestion or the mask is leaking, things like that. Traditionally, what would we do? We would then say, hey, get a new mask and then maybe check the data or have someone check it. If not, they would wait until their next visit in 6 months or a year. Hopefully everything's resolved, unless the patient calls back saying, hey, I still can't use the CPAP. So I think this is a great way that, it's certainly either triggered by the patient, or if you have a system in place where someone is even spot checking the CPAP data and notice that there's, high leak, all of a sudden their hours of usage are less than 4 hours, or the residual AHI is too high. At that point, you can reach out to the patient, get their consent, say, hey, we noticed that you're having trouble or you've called us with an issue. Let's try to address it. And then we're going to, monitor your data for the next 30 days and, hopefully come to resolution. And then someone would have to interact with the patient at least once in that 30 days. And say if the intervention you propose is successful, then I think you could then bill for that 30-day period or continue if there's improvement or the initial issue that was identified wasn't resolved.
The next question is for Tracy. What is the reimbursement for 99091 for Medicare?
Give me one moment here.
While you're looking that up, can you bill 99091 for any patients who are already being monitored for via 99457, for example, pulse ox?
No, CMS is very specific that you cannot bill 99091 and 99457 for the same patient in the same 30-day period. So even if
That
it's
would be double dipping.
pulse ox or another, you couldn't do that.
And once consent is obtained, do patients need to be contacted after the fact if all PAP adherence has been reviewed and addressed?
Billing of those codes requires that you have an interactive communication with the patient in that 30-day window. So you obtain consent, you do the monitoring, and you need to have one point of contact with them, which could be audio, could be an email exchange, but you do have to have an interactive, you have to communicate with them and then communicate them back for this code to be used.
But I don't know if you need to contact the patient again regarding that. You're going to send a charge in, because I think the key is just like any other service we provide, as long as the consent is obtained, what happens afterwards is after the service is delivered or, some interaction occurs.
Oh yeah, sorry, I misunderstood. I don't think you need to contact them again about the charge,
Right.
but you can't obtain consent, monitor, and then, just monitor. You need to have a communication with them during that 30-day period about the treatment and the monitoring. Yeah, sorry. Thanks, Chuck. I think I misunderstood the question.
Yes, what's the reimbursement for
Oh,
99091?
okay. So both facility and non-facility is $53.59.
Next question, what if another outpatient clinic is monitoring a different chronic condition with RPM, for example, CHF or blood pressure? Can both clinics bill for RPM within 30 days? How do providers know if or when other clinics are billing RPM codes?
That is a good question. Let's take that one back and just do more review on it, because I did read something about this yesterday. And if I read it correctly, if you're doing RPM for, say, like sleep apnea, and then someone else is doing it for CHF, there are two different reasons for this RPM. So I don't know if there's a need to coordinate, but I know initially, maybe a couple years ago, there was the fact that only one group could do it at a time. And I'm thinking that that was resolved, but again, I will take a deeper dive into that to make sure, and we'll get back to you.
Yeah, I don't have a ton to add to that, Chuck. I actually saw something that's an area where there is a request for CMS to be more explicit, because there's a lot of uncertainty around that. If you're very strict about how the codes read right now, it probably would be one provider per 30-day period. So potentially there could be two conditions, two devices, and yet just whoever gets the charge in first is who's going to get that charge. But there is a need for more clarification on this. So I think we can take a look at where that's at.
I have something to add here. So for 99453, it can only be billed once per episode of care. An episode of care is defined as a beginning when the remote physiologic monitoring service is initiated and ends with the attainment of targeted treatment goals. So, I mean, that's kind of subjective. So perhaps, you know, the targeted treatment goals obviously would be different for sleep apnea and if the other physician was treating it for CHF. But that's definitely, just to be prudent, we can do more research on that and follow up.
Can the staff work remotely while providing the CPAP monitoring service?
I believe so. I didn't see anything to the effect that that wasn't possible.
Right. For that matter, I guess anyone could be remote. So there was no requirement for where the staff or the billing provider are. It's just that it has to be one provider submitting the bill.
If it is only one night of oximetry, then what code should be used for time spent in reviewing and making adjustments?
It could be the 457. I mean, if you truly, even based on one night of oximetry, end up doing 20 minutes worth of work based on that, if you include a patient interaction in that time.
Is there a calendar limit to RPM or RTM per patient?
In terms of how often, if that's the question, I didn't see anything. I don't think there's no limit. I mean, it could be for 12 months, I think, ongoing.
At
As
the end
long
of
as
30 days, you can start over as long as, yeah.
Yeah. And then I think the key, though, is the whole fact that it has to be medically necessary. So sure, you can bill this for 3 years, but then if CMS comes and say, hey, show us your records about, you know, show us the medical necessity, and then also, you know, the documented documentation as to, you know, what did you do to come up with that 20 minutes worth of work. I think as long as you can do that, sure. But the hard part's, I think, going to be medical necessity for just ongoing RPM.
Can you clarify the difference between 99453 and 99454?
Let's see.
99453 is the supply of the device, is giving the device to the patient. Tracy, keep me honest. And then having them take that, you know, device home with them. And then 9945, oh, and then the education you provide with that. And then 99454 is what you bill every 30 days that they're using the device, as long as it's collecting 16 days of data or more.
Right. So the 453 is a one-time setup code. And then, you know, if you're going to do the 454, that usually would go in conjunction with at least one 457 and then maybe a 458 if you spend 40 minutes worth of work based on the data.
Are you able to share your experience if there are better outcomes for patient adherence or ROI for the practice? Return on investment.
I think it's too early to say. I mean, this is such a new code set. I think people are using it, but I haven't seen any published literature in terms of, you know, is it helping? Presumably it is, and I'm sure as a field we'd be interested. I'm sure CMS is looking at this closely because the uptick in use of these codes over the past few years has, you know, increased dramatically, and that's why the OIG is, you know, looking at these codes carefully. So I'm sure some group is looking at this in terms of longitudinal data, because also too, you have to have these codes used to be able to then look at longitudinal data over 1, 2, 3 years.
Yeah, I haven't seen any sleep specific data. Definitely a huge increase in utilization of these codes since the pandemic, and the data is mixed in the medical literature. Cardiology, endocrine, I think have been using these types of codes longer than we have, and there's sort of mixed data in terms of cost savings, keeping patients out of the hospital, things like that. I think another point too is this might also be a way to get reimbursed for work that you're already doing and are not getting recognized for financially, are not getting reimbursed for. So potentially you already have patients that are complicated, that you are looking at their downloads on a regular basis in 30 days and are communicating with them via phone or via the portal. And right now, potentially you're not really getting any reimbursement for that work. So regardless of how this might look, if it gets picked up more broadly, this might also be a way for you to just get reimbursed for work that you already are doing and have been doing for a while.
Do messages through patient portals count as patient interactions in lieu of patient phone calls?
Dr. DeBruin, you can answer that one.
I believe I have to go back and look at the text, but I believe it says it has to be interactive communication. I don't think either set of codes says it has to be synchronous. So what you want to look at is, does it have to be synchronous or not? So if it has to be synchronous, it means it has to be real time, like a phone call. If it's interactive, then an email or patient portal would work because it's back and forth. And I believe these codes require interactive communication. I don't think that it has to be synchronous. So I think portal would work.
We received a similar question about text messaging, so I think that would apply as well.
But I think the codes some of them do, there is some language in there that it has to be HIPAA compliant. So just make sure you're using a HIPAA compliant platform.
Thank you.
And I think that also kind of leads into, how do you prove that you did something for the patient? So it all comes down to, I think, how you document it. If you're doing it on your own in your EHR, then you just probably have to come up with your system in terms of, based on the data, who does what, and the time they spent looking at the chart, looking at the data, time spent interacting with the patient. Typically a phone call, if it's 5 minutes, then it's just timekeeping in a sense. Just to be able to say that, hey, show us your records, then it's clear that you did at minimum 20 minutes worth of work when you build a 99457 code for that 30 days period of time. And similar to like what we do in clinical documentation for our clinic visits, how can you prove that you did what you said you did? The key is to document as much as necessary. It's not like anyone can say that you did X amount of work, because even for time-based billing, a lot of times it's what you write down. You're attesting to the fact that you spend X amount of time pre-charting, time with the patient, and then after the visit, you don't have to get too granular, but in a sense, it's similar to what we're doing now for clinical documentation for a visit.
Are RPM, RTM codes only for Medicare patients?
No.
But again, I think it depends on each payer. So again, just check with all your payers that you're working with, and just ask them, what the do they even reimburse, and then what their rates are, and they should be able to provide that information to you. And then you can decide if it's worth setting a program up or not.
Can 99453 and 94660 be billed on the same day?
Or 60, which one is that?
That's the plus on.
Oh, that's a good question.
So that's a continuous positive airway pressure, the CPAP initiation and management. Let me try to put it in here. Give me just a moment.
I think that comes back to, setting a patient up with a device. I don't think you can bill both codes. There's going to be a code for setting the patient up with a device and a way to charge the payer. So I think you have to be very careful you're not double dipping, because these are not codes that are meant to be added to codes that already exist. And whenever there's a more specific code, you always just build a more specific code. So for example, there are codes that are specific for anticoagulation monitoring on warfarin. So you wouldn't build a remote physiologic monitoring code if a patient's on warfarin, because there's a warfarin, well, it's not warfarin, but an anticoagulant specific code. But I'll let Tracy, we might need to.
You're correct. So that it does, if our viewing audience is familiar with NCCI edits, it does hit an edit. So it's a misuse of column 1, column 2, which means, in other words, it's not appropriate to build them both on the same day.
But even practically speaking, I mean, they should be done on separate days, because you set someone up, and then even if they start using it, you're going to get data the next day. So that would be the day 1 of the monitoring. So I think it all would kind of, and then even the code you would submit is 30 days after they start using it. So there really wouldn't be a scenario in which you build both, I think.
Would assessing outcomes following initiation of medications be covered under RTM?
Can you repeat that one? Sorry.
Would assessing outcomes following initiation of medications be covered under RTM?
I think so, because remember, there's 4 use cases for RTM. It's musculoskeletal system, respiratory system, medication, adherence, and I think therapeutic response. So yes, depending on what method you use to see how patients are doing, even patient self-report, then yes, I think that's how that code set is meant to be used.
Thank you to our presenters. This concludes our virtual roundtable discussion. If we were unable to respond to your questions during the discussion, please submit them to coding@aasm.org. This presentation will be accessible to members via the telemedicine webpage on the AASM website for future reference. The presenters will also be available to chat with members during the Ask the Expert session at the SLEEP meeting in Houston. Have a wonderful afternoon. Thanks again.
Thanks.
Thank you.